Welcome, everyone. My name is Kathy Nickham. I'm the Education Director for the DTC Ed Center. And welcome to our webinar today, where we will learn the basics about fistulas and grafts. Our program is being recorded and will be available on our website within a week. We hope you'll also complete the brief feedback form that is at the end of the program. Reminder, all of the lines are muted. You're welcome to use the chat box for any questions or comments that you might have, and presentation. It is my pleasure to introduce today's speaker, Dr. Nephrologist. He's the Chief Medical Officer for Hospital Services and Skilled Facilities Dialysis for DaVita Kidney Care. He's also the former Chief Medical Officer for Lifeline Vascular Care and is a Fellow of the American Society for Diagnostic and Interventional Nephrology. And he's also a member of Advisory Council. And at this point, Dr. Mahoney, I'll turn the program
to this topic, one that's very near to me. And I have been, as you can see on the slide here, a nephrologist for over 30 years. Many times vascular access is described as the Achilles heel of hemodialysis, and it certainly can be. And I think it's so important that be very, very well advised and access and learn to be a very informed consumer. It's amazing how patients who are aware of changes with their access and who examine them every day and stay on top of things and ask questions at dialysis, how they do tend to have better outcomes and usually can problem solve before an access has a significant problem. So with that, we will move on. It's very important, of course, to have a permanent vascular access, and there are may have some of needles or they just can't stand needles, and it's also those people of getting rid of their catheter. And the reason it is so important is that a well-functioning access is really necessary to perform dialysis adequately. If you don't have adequate blood flow, then you're not going to have, I see a text about sound, hopefully things are better now. If you don't have adequate access, then it's going to be very, very hard to obtain good function on the dialysis machine. Central venous catheters can cause significant problems with infection, hospitalization, other vascular issues, and the annual cost of care for caring for a dialysis patient with a catheter is significantly higher than it is. And as we know, there is not an unlimited budget within Medicare and Medicaid. Try very hard to be good stewards of resources. The KDOQI stands for the Kidney Disease Outcomes Quality Initiative, and that is a fantastic organization that looks at what can we do to improve dialysis outcomes, to improve the experience for the dialysis patient, to make sure that we get it right. And certainly as technology changes, as we progress and learn, our recommendations that come to us from KDOQI certainly change and change appropriately. The same is true for their dialysis vascular access guidelines. Typically they revise them about every 10 years, and there was a bit of a delay in the most recent release. They were updated in 2006. The update completed in 2019 and then published and made available in 2020. And what I found very interesting and really very impressive about the new guideline for vascular access is it is much more patient-centered. Previously, I'm hearing that there's no sound.
Hi, we are looking into the lack of sound, so hopefully it's taken care of.
Okay, are you able to hear me, Kathy?
I can hear you just fine. I've not had any.
Okay. Okay, so it must not be on my end. Can people just text in and say if they can hear now? It says cutting in and out. Not sure why. Okay, I'll continue on. So the new KDOQI guideline has very much a patient-centered approach, and their motto is the right access at the right time for the right patient for the right reason. Very important concepts in these updated guidelines, and I'm just going to give you the highlights. The patient will want very much a role in this. In the past, it was recommended that everyone should have a fistula. Everyone must have a fistula. Well, the thought now is very different on that access planning should look at your individual circumstances, consider things like your age, your prognosis, your lifestyle, where you are in the course of your kidney treatment, your preferences, social issues, etc., and let those factors weigh in choosing the right access. The patient certainly shouldn't have to do this on his or her own, and so the patient and nephrologist are encouraged to develop a life plan. And what they mean by that is that you plan ahead and are always asking the question, what's next for me? For example, if you have a transplant and your transplant is losing function, are you planning ahead for the time that you may need to go back on dialysis and you can do it smoothly rather than entering into dialysis urgently? Or let's say you're dialyzing with a catheter, but you have a donor and you plan to get a kidney transplant 2 weeks from now. There's really no need for you to pursue a permanent access in that setting. So it's very individualized. About 3 years ago, I had the privilege of going to CMS, the Center for Medicare and Medicaid Services, and speaking with them about what I call the patient's kidney care journey. And as you know, it's not just one event in your life and then things stay static forever. People typically have a long period of chronic kidney disease and then progress into end-stage kidney disease. And of course, the definition of that is that you need dialysis or a transplant in order to be healthy and in order to survive. When you look at the blue arrows in this diagram, what they indicate is that for those who have end-stage kidney disease, your modalities of treatment will change. And as I mentioned earlier, you may have a transplant. Unfortunately, some transplants don't last forever, and you end up needing to go back to dialysis. Are you on hemodialysis and have decided that peritoneal dialysis is the modality that you really prefer and you're going to transition to that? So it is not at all static. It's a very, very constant effort to look ahead, look forward, and see what is coming. Over to the right-hand side, you see end of life, and that's always a very difficult decision, very difficult discussion, but I think we all realize that someday, at some point, we will all reach the end of our life. No one lives forever. And if we can make plans on how we choose to progress and alter our treatment and decide what's right for us and make decisions about end of life, important things like having a caregiver who is assigned to make decisions for us if we're too ill to do so, letting people know our wishes or things that we do and don't want done as we approach the end of our life. All of these things play a huge role in the kidney care journey. That's diverging a little bit from our discussion for today, but I am very pleased that the nephrology community in general is looking at the entire life of the patient and the entire experience rather than what are we going to do this week. So I think most of you on the call, if not all, will be familiar with the types of vascular access, and of course, central venous catheters, arteriovenous grafts, and arteriovenous fistulas are the three main types. Many patients will move in and out among the various modalities, and we'll cover them one by one. Not much time on catheters because we really do want to focus on grafts and fistulas. Unfortunately, in the United States, about 80% of patients start dialysis with a central vein catheter in place. The Fistula First initiative was begun in 2003 in order to reduce the catheter rate, and it has worked long-term, but initially starting dialysis, the numbers are still very, very high. Ideally, a dialysis patient would never have a catheter. We would all be able to plan ahead and make sure that we have an access in place, ready to go when we need to begin dialysis. Now, when we do have central venous catheters, a catheter can be tunneled, or non-tunneled. What that means is when the catheter is placed, if it's going to be remaining in place for more than a few days, a tunnel is created under the skin where the catheter probably has a good 3 to 4 inches of passage beneath the skin, and that provides a nice barrier against infection. Many times we may have an access that works well, but encounters problems and needs a surgical revision or some other intervention, and the access can't be used, and so a catheter may be necessary to form a bridge to provide treatment while that other access process is taking place. And I always love to say that the best venous catheter is the one that you just had removed. The anatomy of catheters, and many people, I'm surprised, I no longer work in an access center, but I did for a little over a decade, and I was surprised how little patients had been told about catheters and what they need to know. The best place to have a catheter, if you have to have one, is what this diagram shows, going into the right internal jugular vein, which is at the base of the neck. And as you can see, that is a straight path down to the heart. If you come into the left side, you've got to pass across the chest because all of the venous structures that drain to the heart pass to the right side primarily. This catheter is tunneled under the skin, and you can see that where you see the external part that has the red and the blue port, and then as you move upward, the V section comes together into one simple line. The gray part is what is external to the skin. The white part is internal. And the tip of the catheter, the very end of it, you can see where it says right atrium of heart. And when properly placed, the catheter actually sits within the upper chamber of your heart. What's very important about that is that there's such an enormous potential for infection there, and maintaining very, very good hygiene and infection control with the catheter is absolutely essential. So what you should know if you do have a catheter is ideally you should get rid of it and get a permanent access. And the reasons are catheters have a very high rate of infection. They must be kept dry. You should never go swimming with a dialysis catheter in place or get it wet in the shower. They may show very limited blood flow rates compared to a permanent access. And the thing that I find most concerning, having worked in vascular access, is that the long-term presence of the catheter in the vein causes an irritation and a chronic inflammatory response within the veins, and this leads to narrowing of the vein and impairment of venous drainage, and that can lead to very painful swelling of the arms and dysfunction of the catheter. Here are some photos of some complications associated with catheters. You can see on the left that it's reddened, and there's sort of a creamy drainage that represents infection. It's often very, very difficult to keep a catheter that has that degree of infection. Very often it has to come out and be replaced later. In the middle image here, you see that the catheter cuff is exposed, and there is a ring of material that's kind of like Velcro in its appearance that sits just inside the skin when you have a catheter. That, like the fuzzy part of the Velcro, it heals into the skin and scars down and forms a nice barrier and closes that tunnel off. That cuff outside of your skin, it means that that protection is no longer there and the catheter needs to be replaced. When you see the cuff exposed like that, never push the catheter back in to bring the cuff under the skin. That will guaranteed end you up in the hospital with a serious bloodstream infection. The panel on the right is significant arm swelling, again, related to narrowing of the central veins. And one of the difficulties with this is that it's very, very hard if we do dilate the vein and try to improve flow. It's very hard to keep the vein open. Typically, this degree of this degree of swelling is very, very hard to get rid of when it recurs. That's all we're going to say about catheters. With regard to grafts, a graft, as you know, is a synthetic tube that has blood flow from your artery to your vein. And as you can see, in the diagram here where the white tubing is connected to the red, that's the arterial connection, and to the blue, is where it joins your vein and where the blood will return back into your system. There are many places that grafts can be placed, most typically in the arm, whether the forearm or the upper arm, but they can be placed in the thigh, in the chest, basically anywhere where there's access to an artery and subsequent drainage to a vein. In the past, as I mentioned, we were very, very intent on making sure that everybody got a fistula. Many patients, for any number of reasons, don't have good blood vessels for creating a fistula. And they may have multiple surgeries that fail, and they become very disappointed. For those patients, a graft is an excellent alternative, typically will work quite well when the best spot to place it is identified and we're able to bypass those areas where the blood vessels may be diseased and won't provide a good access. The grafts typically don't last as long as fistulas do. Where properly maintained, they can last for many, many years. I thought I'd put together just some commonly asked questions about grafts. And over the years, I was a practicing nephrologist for about 30 years, and these questions came up many times. Many people will ask why their grafts have areas that are bulging. Why is their graft clotting a lot? Why does it take so long to stop bleeding? The graft is failing. What does that mean? Why should they not have an IV in the arm with the graft? And they've had a transplant, and the graft is no longer working. Should it come out? So we'll address these one by one. This is a very common appearance, and you can see that in the lower part of the image, you can see the black marks on the skin where the needle cannulations have been. The graft is relatively normal in size at that point, but on the upper part, very, very dilated and lumpy. And the reason that exists is that the graft material itself is effectively gone. It has disintegrated with the multiple needle sticks over the years. And in the areas where it's bulging, the graft material is essentially gone. You may wonder, well, why don't you bleed extensively under the skin? When the graft is placed, your body heals around it and forms a very nice scar. And that scar actually forms a nice channel so that if there is a hole in the graft eventually, it's contained. And what you're seeing in the swollen area is that the skin has dilated out. It's similar to blowing up a balloon. If you have this occurring with your graft, it's not because of anything that you are doing or not doing. It's the result of long-term use, and it's very common. Many times patients will go to their surgeon and have that portion of the graft removed and replaced. And typically, these areas are stable and sturdy, and it's all right to use that area to place needles for dialysis, but eventually that's going to need to have a surgical revision. What about your graft clotting? What happens and why does a graft clot? It's due to reduced blood flow. The blood flows down usually due to a blockage in the vein, most commonly where the graft material joins the vein. And as blood flow drops down low enough, or blood pressure drops extremely low, and that causes a low blood flow, clot will form. In this image, over on the left-hand side of the picture, you'll see that little white arrow. That is pointing to the clot. So to orient you to this, at the bottom of the image, that dark black vessel is the artery. Where the graft is connected to the artery is at the very left-hand side of the diagram. And then it flows upward, so upward and to the right, and then back down, and drains to the right. And you can see that whitish area by that arrow is all clot. Over to the right-hand side of the diagram, you'll see something that looks like almost a basket, like a woven material. That is a stent, and that is a wire tube that in the past has been placed there to try and keep the vein open. They do tend to work for a fair amount of time, but a stented vessel will very often close down again in the future and require an intervention. If you have a graft that's clotting frequently, it's very likely to fail, and so before it fails completely, speak to the surgeon about having a new graft placed or a revision. When you have prolonged bleeding in your graft, what I mean by that is that it takes longer than it usually does for blood to clot. And so most people will say, they pull my needle, I hold my site for about 5 minutes, and then I'm fine. But recently, I've had to stay as long as 25 minutes to get the bleeding to stop. Usually that will be due to a narrowing in the area where the graft
Correct number. Please verify and try again. I'm sorry, your entry is not valid. Please contact your meeting organizer or dial the support number provided on your conference card to obtain the correct information.
key, and I love machine were not invented just to drive people crazy. They signify when there's a problem. And so when you're on dialysis, if your machine is alarming frequently and there are pressure problems, the vast majority of the time it's because there's a problem with your access. That's a good time to speak up to your nephrologist and say, my machine has been alarming a lot lately. I'm wondering if we need to have a look at my access and see maybe if it's developing and narrowing. The vast majority of the time, there probably is. Another indication that your graft may not be working adequately is when the dialysis team has to turn down the blood flow rate. And your dialysis order may say to run the blood pump at 400 cc's per minute, but when they do that, the machine stops and it alarms because the pressures are too high, and they have to turn it down to 300 or 250. Again, that's an indication that the access may have a narrowing. Many times, the surgeon can replace a part of the graft that's not working well rather than having to replace the whole graft. And the great thing about that is your graft is immediately usable. You just place the needles in an area other than where the repair was done. Love to say that the access arm is sacred, and I'm sure you've all been told no blood pressures, no IVs, no blood draws in your access arm. Well, why is that? Well, first off, blood pressure cuffs and tourniquets can make your access clot. You certainly don't want to do. You don't want to wrap anything circumferential, anything that goes arm to generate, cause a clot. Also, there is a certain amount of training and expertise that is necessary to needle in a dialysis access, and you only be done by people who are appropriately trained and experienced. Those who do not have experience in training, cannulating an access, very often won't be quite sure exactly how they should do it. They may pass the needle through the deep end, sort of the bottom end of the fistula. Very hard to control bleed happens. There also is a risk of infection anytime that an access is entered, and we want to make sure that proper infection control measures are taken. So protect that arm. And again, you may wonder, why can't they use this for other things? Because the risk of damaging that access or causing infection is very, very high. A lot of times we get a question about, I've had a transplant, I don't need my graft anymore, should I have it removed? And the answer is, it all depends on your own individual circumstances and the advice of your surgeon. Interestingly, many grafts fail and stop flowing within a year of a transplant anyway. And so you really don't have to have the graft tied off because it's probably going to stop on its own anyway. Once that occurs and the graft is completely clotted off with no flow, it really is no longer part of your circulation. Very, very unlikely that that will become infected or have bleeding problems once that occurs. You need to remove a clotted graft. If you have a graft just sitting there in your arm, it's not going to cause any problems. As I mentioned, almost immediately after placement, the grafts begin to heal into the surrounding tissue, and it's a very, very large to have a graft typically associated with a long healing to your arm in there. Sometimes there are people who have cardiac reasons, heart reasons, why they really should have their graft removed or have it stop functioning. In those settings, it actually is very rare to remove the graft. More commonly, if the cardiologist recommends that the graft no longer function, we'll go in and essentially tie a thread around it and tie it off, tie a knot, stop the flow, and let it clot. Again, it's very rare to need to remove them, typically only in the case of infection. We'll talk now about fistulas, which are, for most people, not for everyone, but for most people, the access of choice. It is they have the longest lifespan, they tend to have the fewest complications, and the rate of infection with fistulas is much, much lower than any other type of access. So how is a fistula created? A surgeon takes your vein, attaches it to your artery, and that is all. There's no, typically the suture that they use to sew the vessels together is dissolvable, and so that will disappear after X number of weeks. And so a fistula is your own native material, and again, very, very unsuffer infection. The downside to a fistula is that usually requires 4 to 8 weeks from the time it is created until it develops and can be used for dialysis. And not everyone has adequate blood vessels for a fistula, so having your surgeon evaluate your blood vessels, decide if you would be a good candidate for a fistula is very, very important. And most surgeons will schedule an appointment ahead of time to do a very dedicated direct ultrasound where they personally can see what the status is of your vessels so that they are more likely to have a good, successful outcome. The most common sites for fistulas are the forearm, and these diagrams are very, very simple but very straightforward. You can see on the left that the blue vein was divided, and if you look closely, just under the wrist, you can see where that vein is tied off. In the image, they have a piece of suture tying off that stump of the vein, and then the vein is connected to the artery, and the flow is directly from artery to vein, and that is a fistula. It takes several weeks to develop, but that's all there is to it. That's if you have it in your forearm. In your upper arm, there are 2 vessels which are commonly used. The cephalic vein is the one that runs right on the top of your bicep muscle, on the top of your arm. And if you've seen weightlifters that have this huge vein in the center of their upper arm, that's typically the cephalic vein. The basilic vein, which is the one which is shown here, lies over to the side of your arm. And in the diagram where it says transposed vein, and you'll notice that there's sort of an arch to it, the vein actually used to lie parallel to the artery, and the surgeon has moved it and created that arch to it so that it's easier to access and for the dialysis team to place needles. It would be very, very hard to place needles in the area on the underside of your arm. And so typically a basilic vein fistula, which has a very high success rate in terms of placement and function, that's why the vein has to be moved. It's really important to know about your fistula and to be very, very aware of any changes. Examine your fistula every day, and it'll only take you a few seconds. You should have a steady thrill, and what that means is there's a buzzing sensation like a cat purring or like a motor humming. Think about if you rest your hand on top of a clothes dryer when it's operating. That's what the thrill should feel like. If you raise your arm above your head, assuming your fistula is in your arm, there are some that are in your leg, the fistula should soften and collapse. When you drop your hand down below your waist again, you'll see the fistula fill. That's important because it shows that there isn't any blockage to the fistula draining well, that when you raise your arm and gravity goes to work, blood flows very easily and completely out of your fistula and into the veins in your chest. That need not happen for everybody, depending upon the blood flow rate, the size of the vessel, etc., but it definitely should soften, and you should notice that the fistula is not as firm as it was when your hand was down by your leg. I encourage people to get a stethoscope and to listen to their fistula every day, and it should have a soft whooshing sound. And if you've ever had an ultrasound where they use the vascular probe, you'll hear the system going whoosh, 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 whoosh. That's what your fistula should sound like when you listen to it. There should be a constant sound, and it should be that low-pitched whooshing sound. You hear a high-pitched whistle, or if you hear the sound intermittent where you hear sort of a squirt and then it's quiet and a squirt and quiet, that's a fistula that has a blockage in it. And if you hear that, definitely speak to your nephrologist about a referral to the surgeon for that. I have a couple pictures coming up, but the skin over the fistula needs to be intact. And if you notice that the skin is very shiny, or the skin has become particularly thin, or appears to be infected, that is a surgical emergency and needs urgent attention. The upper image here shows a very large fistula. Some people will call this a megafistula. That is one that is probably the result of high pressure or high flow over time. It's completely safe to use that, and there's not a problem with it unless the flow is so high that it compromises heart function. And again, that's where your cardiologist and your surgeon will come together and decide the best approach. The image on the bottom is one that is very, very concerning. You'll notice a few things. Number one, skin is shiny. And that usually means that the skin is tense and stretched. Number two, the skin is red. And that signifies that there very likely is infection there. And if you look slightly to the left of this bump, I'll call it, you can see there's a whitish area, and it looks as though there's a little dimple. That is probably a needle site fully, and those have a very high likelihood of rupture, meaning that the fistula can burst with uncontrolled bleeding. So the dialysis team is very well trained. They will recognize this as an emergency if they see it. Home dialysis patient, and you see this, you need to contact your physician immediately. What about a clotted fistula? We don't see them as much, thankfully. Grafts tend to clot more often than fistulas, but fistulas do clot, and it's very, very important to have the clot removed promptly. Sorry, I left the T out of promptly. It does become more difficult to perform that procedure as time passes. So if you are listening to your fistula every day and you notice that the bruit, the sound of your fistula has stopped, and the thrill, the buzzing feeling has stopped, notify your doctor immediately. Some questions that have been asked. Why can't I use my new fistula right away? I was able to use my graft in just a few weeks. Excuse me. And the reason is that the fistula is a vein that has not previously been accustomed to high flow. And as the blood flow increases dramatically from the artery into the vein, that vein will grow and become large enough and have high enough flow to sustain dialysis. But it takes time for that to happen. Why isn't my fistula maturing? Very frustrating. Well, actually, in the United States, more than half of fistulas don't develop to the point that they can be used unless an additional procedure is performed to help them develop. And that may be dilating a narrow place in a blood vessel. That may be repairing a place that following creation of the fistula, the body actually tried to heal it and close the opening degree in the vein. Many people will have what are called accessory veins, where unfortunately, when the blood goes into the vein where it's connected to the artery, it may drain into a number of veins, and you don't get one dominant vein to create a workable fistula. And again, that is easily treated, but it has to be recognized. Very commonly, and I often hear this in older people, I had 3 attempts at a fistula. I don't want to try again. Why can't I just keep a catheter? Well, again, catheters have so many potential complications. They are the least desirable access. That person should speak to the physician, to the surgeon, about having a graft. A graft may be a very, very reasonable alternative for that person. My fistula keeps getting bigger. Is that normal? Well, a fistula should continue to enlarge, but usually once they get to about 6 to 8 millimeters, and that's about 1/3 of an inch, ideally they should stay about that size. Why do they enlarge? Again, very, very high flow, and sometimes people will have a blood flow that is literally 50% of their entire circulation going through their fistula. The surgeon can do a procedure called banding, where they reduce the flow to an appropriate rate. That's much better for your heart and much better for your overall health. Another reason that fistulas dilate is that they are under pressure due to narrowing, and it's exactly the same principle. Think about if you've ever seen anybody do a balloon animal. They will pinch the balloon and inflate it. And the balloon inflates very nicely up to the pinch and doesn't inflate behind that. The reason there is that the pressure between the mouth much greater than the pressure behind the pinch, and the same is true when there's a narrowing. So if you notice that your fistula is enlarging, again, it may be necessary to have it looked at to see, is there a narrowing that can be treated and prevent abnormal enlargement? The next question, my hand, my fistula arm is cold and aches, especially during dialysis. Is that normal? And the answer to that is no. If you have a cold, painful hand, that means that you're not getting adequate blood flow to that hand, and you actually can lose function or even lose the hand. And so if you have a cold and painful hand on the side of your access, make sure that you let your nephrologist know and let your surgeon know, because there are measures that can be taken to improve the circulation to your risk of losing functions. That's the material that I had to present. I'm always happy to answer questions, and I hope some will come up in the chat here. I think it's very important that all of you do what you are doing. You wouldn't belong to DPC if you weren't your own advocate. And I think participating in these webinars, learning what you can, going online and resources, and being a very, very active patient will certainly be something very, very well in terms of your future health. These resources, of course, the educational program from Dialysis Patient Citizens and other resources they have are just invaluable. The National Kidney Foundation is a very rich source of information. Same can be said for the American Association of Patients. And one of the things I would encourage you to do is to speak with your nephrologist and your dialysis provider, particularly the dialysis nurse, social worker, dietitian, when you have questions, because they all have very, very specialized training. For the most part, work only with patients with kidney disease, and their expertise is impressive. And the only foolish question, one that you don't ask. And I've been amazed when I worked in the Vascular Access Center that I would give patients a brief description of what had gone on with their accesses and what they could do, ideally, of troubleshoot films. And I can't count the number of times that they would say, "Thank you so much. That's the first time anyone ever explained me." And we get the need for ongoing education. But I find that patients who do become very, very aggressive about their education are the ones who do really, really well, and also our patients. And we'll show them, yes, we can do this. Together we can do this. That's all I had for presentation. I wanted to see if there are any questions.
encourage people. And do you have some suggestions on where they might do that, especially for people that don't Google and find things on Amazon?
Okay. One thing to do is if you go to a vascular access center for a procedure, many times part of their process is to show patients how to examine their own access, and they will give you a plastic stethoscope. It looks like a toy, but it's not. It actually functions very well. I believe, too, that if you go to places, I believe CVS and Walgreens and others will often have stethoscopes, and you need not get an expensive one. Get the cheapest one they have because it will be perfectly sufficient.
Thank you. Thank you for that information. Does look like there's a question.
I see the question about the pseudoaneurysm.
Okay.
Okay, and the pseudoaneurysm is exactly, I'm going to go back to that picture, exactly what you are seeing in that dilated area. And again, an aneurysm is when a blood vessel develops a weak point, typically an artery, and bulges out. Think about a tire that has an inner tube, and you see the inner tube bulging out. A pseudoaneurysm is where it's not the blood vessel that's bulging. In this case, the graft material is gone, and that bulge or pseudoaneurysm is actually just scar material through which the blood is passing. Pseudoaneurysms are very common, and they're not a problem unless they have a high frequency of clotting, or they are rapidly enlarging, or they bleed. But the pseudoaneurysm in and of itself is not a problem. I see someone is typing, so we'll wait for the next question as well. And I can tell you again from, let's see. The next question here, and there may be some of you who are on the phone and don't have the video. What do you suggest for a patient who is fearful or hesitant of removing a CVC? They have been educated on risks. That is a very, very common issue, and I think that educating them on the risks is clearly the best place to start. And I try to find out what is it that they, the reason that they are avoiding having the CVC removed, and there are many. One is needle phobia. and patients are afraid of needles. They're afraid it's going to hurt. And I would tell them that we do have available things like EMLA cream and can anesthetize the skin so that they won't feel the needle. Some people are very worried about the cosmetic effect. I don't want one of those big ugly fistulas in my arm. And one of the things that we can do is to suggest that they talk to their surgeon about a fistula in their upper arm and explain to them that a well-monitored and well-cared-for fistula tends not to get dilated and huge. It's the one that develop blockages or narrowings that go unaddressed that tend to be large. Some people view it as a final admission that their kidney function is not coming back. And that, of course, is more a social issue for them and a sort of a acceptance of a big change in their life. So I think finding out the reason that they are hesitant, explaining the pluses and minuses, and again, we're not going to force anybody to get rid of their catheter, but I think explaining to them catheter patients on average spend almost an additional month a year in the hospital. And patients would rather be home. And the risk of hospitalization, the risk of infection, the risk of infections of their spine, of their heart, I think sometimes we just have to show that the risk-benefit ratio is such that so many more benefits to getting the catheter out. Great question about options for controlling pain before needle placement. The EMLA cream is, I think, the most commonly used. In the past, I've seen many times where there would just be lidocaine injected under the skin. So you get a local anesthetic, and again, it's a needle stick, but it's a tiny little needle, and the numbing is immediate. So some places will numb with lidocaine. I haven't seen that done so much in the recent past. One thing I would definitely avoid is I had a patient ask me about using those sprays that quote freeze the skin, and those are fine if they are used very, very rarely. But for somebody who's going to be using one of those in 2 sites 3 times a week, what happens is they end up necrosing the skin. And what that means is that the frequent freezing and thawing actually kills the skin. It turns black, and they have to have the skin removed and the skin graft placed. So we definitely advise against using those anesthetic sprays if they are the ones that quote freeze the skin. Other than that, those are the things with which I'm most familiar about controlling discomfort with needles. Another thing that I will mention, though, is people who have a fistula will ask about doing cannulation, at the same site and using the dull needle, and that is associated with a much greater risk of infection and And we generally do recommend what's called the rope ladder approach, which means that your needles are placed in a